prostate case. There was this gentleman who had prostate cancer, and he had this finding in his, so this is the prostate cancer here, but he has this finding in his osseous structures. And the point that I wanted to share really quickly with the group was, if I can, so I can't show the ROI because it gets taken away when I take the patient's information away. But when we put ROIs on in and out of phase gradient echo images, the lesion did have interlesional lipid, and fat in an osseous lesion is benign, and this was a hemangioma. So we that's how we classified it on this prostate MRI. And this actually was concordant with the patient's clinical known clinical parameters. His PSA was lower than would be expected in somebody who would have osseous metastasis, and there was no lesion on a recent nuclear medicine bone scan or a pelvic CT that was done about a month before this examination. So that was one
Ben,
case.
I have that's really cool. I was actually wondering if you could see the hemangioma on the CT, because I have seen, I think like my MSK colleagues have told me that pelvic hemangiomas are rarer than lumbar ones, but also possible. So we should think about those. Could you see them?
I'm actually gonna try to. When we were looking at it, we really couldn't see the lesion well, but it's somewhere in this region. But on CT, it's not really well seen.
And then I have T2s? One more. Oh, go ahead.
I was just going to ask, do you have any T2s, T2 weighted sequences?
We do actually have a T2 weighted sequence.
Because hemangiomas would be bright on T2, so.
You know, the T2 weighted sequences that we have are kind of a little bit limited in their. Let me see if I can find you a larger T2. Maybe on here.
Yeah, you can see it on there. Keep going forward. Other way. Stop.
Oh, here.
Nice. Yeah, that's cool. And then I have one other thing that I'm curious what the group thinks about this. I was my MSK colleague, like I always tell people like, oh, if it has fat in it, that can't be a MET. My MSK colleague recently told me that early METs can have fat in them because the metastatic cells can interdigitate with the fatty marrow.
Oh, wow. That's really good to know.
I know, but he really messed me up because
I was kind of using this as a, oh, if it has fat, I can just write it off, but apparently not. But this was a very interesting case, and I just wanted to share that with the group. I have another one. This one actually really, I think, was one of the best cases that I've seen so far. It was a young lady. She's in her 30s or 40s, let's say. And she was referred to us for a liver lesion. But that's much, much less interesting than the finding that I wanted to share with the group. So one thing was that she had some splenomegaly going on. A lot of people have it, and we kind of write it off sometimes. But when we were looking at the liver to kind of try to characterize the liver lesion, we noted that the signal intensity from the liver doesn't really look right. We were looking at it, and we were kind of trying to figure out what's going on with the patient. So let's ignore the liver lesion. That's not as important. But I think the key sequence that really helped us out here on this examination was the diffusion sequence. And you can see the liver has abnormal signal in it throughout. But then when you go down to the kidneys, those are also really, really abnormal. And there's also some stuff in the bone marrow that's really, really abnormal. So we were fortunate that a day after this exam was done, they actually did a bone marrow biopsy on the patient, and it came back as lymphoma. So that's what this all is. This is diffuse infiltration of the liver, kidneys, and bone marrow with lymphoma, and that explains the signal intensity in the organs that we discussed. Incidentally, that lesion that we were looking at, we felt that it may be an adenoma, but that was the less important, or from my perspective, that was the less interesting finding in this patient. So I just wanted to share. I feel that diffuse processes are sometimes difficult for us to appreciate because there's no real difference to pick up on, and you have to kind of be very careful when you're looking at the examination to pick up something that diffusely involves the entire organ. So that was one
Ben,
other.
that's a great case, a great example of like an infiltrative process that just blends in. Can you show us the T1 pre? I had a case that was like this, that was breast cancer mets, lobular breast cancer mets, like diffusely spreading. Wow, you can't even see it there. It's just like
You really can't. You really can't.
blending
You see that lesion that they were asking us about, but if you had blinders on or you were reading very quickly, you could miss the larger process that's going on. So this was a really great case, and I just wanted to share that with the group.
And Kedar said Gaucher, which I previously had showed a picture, a case of like Gaucher's type 1 of the spleen. And then Rupa says, nice, DWI has definitely helped us with kidney stuff like multifocal pyelo. Agree.
All right, thank you very much. I'm going to stop share. Yes.
Yeah. Okay. Okay, so this is my first case, and the patient has cystic disease of dialysis. You can see lots of little cysts. And this is the case is about the gallbladder. So the gallbladder was distended. There was a little bit of stranding next to it. So we were concerned about acute cholecystitis. But there's one finding here that I wanted to point out, which is that you can see that the fundus of the gallbladder is bulging a little bit. And I'm just going to show you also on the sagittal. So you can see it's kind of bulging here. And this is what's called the bulging fundus sign. And I'm going to show you a slide. Aya Kamaya at SAR showed some of her favorite subtle signs of acute cholecystitis. And this is one of the signs she talked about. So when you have bulging of that fundus or wall there, think about cholecystitis. They did not do anything. This patient was an inpatient, had multiple other issues. And you can see now that that area that was bulging has actually perforated into the liver. And so we've got some contained bilomas in the liver that was not there 1 week prior. So I thought it was a nice example. The other thing that Aya talked about was that the length of the gallbladder can be more specific even than the luminal distension. So she said in luminal distension, we talk about 4 centimeters. I think this was like 7. But then the length, she said, if it's greater than 8 centimeters, that's also even more specific for acute cholecystitis than the luminal distension. So just a couple of.
So Aarti, I have a question.
Uh-huh.
So you call them bilomas. Are they bilomas or are they intrahepatic abscesses?
Well, I think of those as the same. Like I see it as like a ruptured gallbladder into the liver. And it could be infected or it could be just bile. It's kind of like the same thing as acute cholecystitis. At some point it becomes infected, right? What do you think?
Right. I mean, the imaging wise, it looked more like abscesses. So I was just curious that, like, would you need to put in a drain and drain them?
Yeah, I mean, I definitely think like at any kind of time you have a biloma, it's on the spectrum of cholangitis and abscess. And if it's big enough, I would say we could drain it. In this case, I advise them to just put in a percutaneous cholecystostomy tube to treat the underlying inflammation. This one I think is not necessarily big enough. We usually use 3 centimeters. But you know, if it got bigger, then we would definitely use that.
Okay.
But I mean, it could just be the same way that like cholecystitis can just be obstructed bile. It doesn't necessarily have to be infected, right?
Right.
So anyway, I just wanted to show you, you guys see this. So these are the signs that Aya talked about at SAR. So the length greater than 8 centimeters, sludge, which she said you should not see as an outpatient. I am not totally sure about this because I feel like a lot of people here have sludge, but there was a debate about like, what is sludge exactly? And so she was talking about sludge on ultrasound. The hyperconcentrated stuff that we see layering on CT and MR might just be hyperconcentrated bile, not necessarily true sludge, which is cholesterol coming out of solution. This bulging fundus sign, discontinuity of the mucosa. On ultrasound, if you see echogenic fat around the gallbladder. And then also this one she really likes is the hepatic arterial velocity. I will say that this is if you have really good ultrasound techs and, you know, great ultrasound department, maybe you could do this. And the velocity greater than 100 centimeters is suggestive of inflammation and cholecystitis. Okay, I'm gonna do my next case. Oops. Okay, so this patient got a G-tube. And you can see the G-tube here, and you can see the T-fasteners. And what do you guys think about this? This was 6 days after, after G-tube placement. And you can see that there's tons of free air. So do you guys think that is within post G-tube?
Way too much.
Not at all. Yeah.
Okay, so yeah, so what do you think, Teresa?
And that's never an appropriate post-surgical or post-G-tube appearance.
So I will tell you, I've seen cases
Have you
like
seen
this.
that post-surgical? Okay.
Well, I've seen it in the immediate post-surgical setting and have just, and usually the patient's asymptomatic. So I've stopped kind of being as worried post G-tube. And I think it's because, especially when GI does it, they insufflate the stomach, right? And then they like push it up to the surface and then they put a needle in it. And so basically all of that air that they use to insufflate the stomach suddenly goes out into the peritoneal cavity. 6 days post-op, we thought maybe this is definitely too much. And this patient had symptoms. One pertinent negative I found, I think, is that there's no fluid and there's no feculent material, because they were wondering, could we have crossed the colon? Could we have perforated the small bowel? And I find that when I don't see any of those other like fluid or feculent stuff, then it's probably just air coming out of the stomach. So we did a fluoride. They wanted to test this. So we injected contrast through the G-tube with the patient prone. I've flipped the images, but this patient was lying on their belly so that we could see if there was any leak around here. And you can see that there's still tons of free air and there was no contrast extravasation. So the patient went on for like a few more days and it was still like this and they were still having symptoms. And we ended up doing a paracentesis where we removed 1 liter of air from the abdomen. So it was basically relieving a abdominal compartment syndrome by doing a paracentesis to remove this air. So I wanted to show you, where did my, okay. This, I was just reading about it online. So basically it's very common to have pneumoperitoneum after G-tube placement. It happens in up to 20% of patients. A lot of them don't have symptoms. The air can take up to 18 days to resolve. So even post-op, we know that. The etiologies can be bowel perforation. This is more common if you actually see fluid or other kinds of material in the abdomen. And you can test this with a leak study by injecting the G-tube. But also commonly you can get an air leak either from where the G-tube is going into the stomach or from the peritoneal stoma, which is rare. So I think in my case, this was probably a leak from the peritoneal stoma, which means that air was kind of going in a one-way valve from the atmosphere into the abdomen for some reason there was lower pressure in the abdomen, and it was kind of filling up over time because his symptoms got worse over the 6 days after G-tube placement. And so I think the air was able to enter the abdominal cavity and not get out. And this was a similar case report where they got tense pneumoperitoneum over time after a peg tube placement, and they also thought it was from the abdominal wall stoma.
So did they have to revise it, or is it just?
No, I mean, actually, after we did that, after we alleviated that, they actually did some dermabond at the skin site to try to make the skin site smaller. After that, it did not reaccumulate. So that was that case. Okay, this is my next case. This is a vascular case. Focus in and around the liver. What do you guys think?
There's no portal.
Yep, there's no portal vein, and it kind of looks like, there's a enlarged hepatic artery here. You don't really see all the tangle of vessels of cavernous transformation. And then there's another finding on this image here.
The splenic opens directly into the IVC.
Yeah, exactly. So this is the SMV splenic vein, and it's draining directly into the IVC. So do you know what that's called?
Cavo-splenic shunt.
Yes, good. So actually, sometimes they'll do this surgically. If you want to do basically you're trying to make almost like a TIPS, but this can also be congenital. This patient didn't have any surgery. So this is what they call an Abernethy malformation, which is basically congenital absence of the splenic, of the portal vein. It was described by Abernethy in 1793. So we're going way back. And there's several different types. So you can have your splenic vein and your SMV draining directly into your IVC. You can have them form a type of portal vein, but that doesn't go into the liver, that goes directly into the IVC. And then there's another one where there's a connection between the portal vein and the IVC. So some of the things you can imagine that this can cause encephalopathy because you're draining your splanchnic circulation directly into the IVC. This can also cause hepatopulmonary syndrome. I kind of had to look up what this is, but about 20% of patients with cirrhosis actually develop hepatopulmonary syndrome. This is when the liver produces nitrous oxide and other types of angiogenic factors that end up in the lungs, and that causes proliferation of AVMs and telangiectasias. And this really decreases your oxygen exchange and can cause a lot of pulmonary issues. And then some people with Abernethy malformation can also have associated cardiac and biliary abnormalities. So people are saying, wow, nice one. I'll never forget it. Good. Actually, my fellow Omar retaught me about this. All I knew about Abernethy was, congenital absence of the portal vein, but I didn't know, how you could distinguish it from just cavernous transformation. I didn't realize that it means that you also have a shunt that goes directly from those splanchnic vessels into the IVC. Okay, this is my next case. Chat it in or speak up. So we've got a mass in the abdomen. And as we go into the pelvis, we also have some lesions in the pelvis. So pelvic stuff looks like fibroids. We've even got some engorged pelvic veins here. So do you guys think this is a exophytic fibroid? I can show you the coronal also. And it looked like there was something in the gonadal vein here, as well as up here, something in the IVC here. So do you guys favor this to be a fibroid, a pedunculated fibroid, a parasitized fibroid, a leiomyosarcoma? What do you guys think?
I think you got to worry about malignancy on this one.
Yes, Excellent, good. So even though, fibroids are common and you want to always lump things together like Occam's razor, as we just heard about at the SAR film panel, you can also have Hickham's dictum, which is a patient can have as many diseases as they want. So these fibroids look more typical. They're very well circumscribed, but this thing is lobulated. It has different parts to it. It has this necrotic part. It's also in the IVC here, as well as in the gonadal vein. So anyway, it turned out to be a leiomyosarcoma. And we couldn't really tell if it was actually rising from the IVC or the gonadal vein. It was involving both, but I'm thinking maybe it was from the gonadal vein and then also grew through another vein into the IVC. Francesca is saying sarcoma and Rupa is saying leiomyosarcoma, which got into the vein. Excellent. So just a couple of points about leiomyosarcoma. So a couple of things just about leiomyomas. So the leiomyomas and leiomyosarcomas have a higher incidence in the African-American population, both 2 to 3 times increased incidence of fibroids, but also a 2 times increased risk of leiomyosarcoma, according to UpToDate. Although fibroids and leiomyosarcoma, even if they're of the uterus, are not related to each other. So you do not get progression from a fibroid to a leiomyosarcoma. They're thought to arise from completely different cells. The other major risk factor for leiomyosarcoma is an age. So if you have an enlarging mass, if they're premenopausal, actually in UpToDate, they were saying that that's more likely just to be a growing fibroid, and like a growing mass in a premenopausal patient is actually not an indicator for that it is definitely going to be a leiomyosarcoma. And they did a huge retrospective review of that. But if it's a postmenopausal patient, then that's a warning sign. And on imaging, it's super, super tricky, but you can look for ill-defined margins, hemorrhage, lack of calcification, and lack of T2 darkness, which is more of a sign of fibroids. And diffusion does not really help. So in this case, this was patient with fibroids as well as an IVC leiomyosarcoma. And even though it's more common in older patients, this was actually a patient in their 30s, so it can happen. Okay, next case is this one. This patient, you can see they've got some dilated bowel loops. They have this thing here. Oops, there's an arrow sign. So there's something there as well. I can show you on the coronal. What do you guys think?
Kind of looks like a partial obstruction and then there's maybe a fecalith proximal to it.
Yeah, good. So we thought this looked concerning for an adenocarcinoma. It looks circumferential, like an apple core. Even though those are rare of the small bowel, you can get them. And then we thought exactly that there's a partial obstruction. And then this thing up here we called a Bezoar. And this did turn out to be a Bezoar. So Bezoars are not just in the stomach, and they're not just from eating your hair, which is a trichobezoar. You can also get them in the setting of a sort of chronic partial bowel obstruction where food gets inspissated, especially certain types of like fruits like persimmons or other kinds of nuts and food material. So we basically think that this food was kind of pulsating against this area here and eventually caused this Bezoar. And then we thought this was probably an adenocarcinoma. They went for resection, and this actually turned out to be a lymphoma. The patient then got a PET scan, and there was no other sites of lymphoma except these lymph nodes were all resected also, and they also had lymphoma in them. But this was basically thought to be a primary GI lymphoma. So I thought this was interesting. I hadn't seen, and it wasn't aneurysmal dilation like we normally see with lymphoma. So I have just a couple of points about lymphoma. So the GI tract is the most common site of extranodal lymphoma. 90% are going to be B cell non-Hodgkin's lymphomas. And so we do have lymphocytes in our gastrointestinal wall, and that's what predisposes to lymphoma. There are certain ones in certain parts of the bowel. I can't really remember most of these, but I know that Malt's lymphomas can be in the stomach. And then some of the risk factors are having H. pylori, celiac disease, and a number of infections, as well as inflammatory bowel disease and immunosuppression.
Okay, hopefully you guys can see the CT.
Yes.
This is okay. So this person I got called from one of our sort of satellite hospitals for someone who had signs of infection and recently had surgery. And so I'll withhold the rest of the details just to see if anyone else can sort of identify what might have happened here. But I'm happy to give more if we need to. Aarti, I'll rely on you to look at the chat for anybody. So sort of the key elements are down here in the pelvis. And some of the clues to what might have recently happened are down here. Anybody have any idea? So one thing that's sort of a clue here is the genitals. Looks like there's something that's happened down here.
Yeah, Ross, sorry, what surgery did you say they had?
Oh, I just said they had surgery.
Some kind of gender.
Yeah, so I had that history, but you can sort of tell what happened, or you can, I think you can tell what happened here. So this was a male who was doing female transition and having surgery to create basically a neovagina. And so you can see they resected the penis and the testicles, and you can see some of the post-surgical stuff here, but they had a lot of signs of infection. And so we were looking in the pelvis here, and I don't know if you guys appreciate this, but these loops of bowel here look pretty sick to me, or I thought they looked pretty sick, and that's what I told the surgeons. Anybody have any idea what that might be or what might have happened in this surgery?
No, please educate us.
So at any rate, when you're doing a male to female transition, they want to have some sort of neovagina, basically. And as far I haven't seen a lot of these cases, but it seems to me like the sort of standard or the most optimal one is to do a penile inversion, which I'll show some diagrams of that I found just searching on the web. This one, they actually take a segment of ilium and bring it down into the pelvis to use that to create the neovagina. And there's a few other ways you can do it with other loops of bowel, including the colon, and even like using skin grafts and stuff. Well, I think it's kind of archaic technique at this point. And so you can see up here, this is where they found, so basically when they went into surgery, they try and find some segment of ilium that has sort of healthy mesenteric supply, like a healthy arcade vessel, and they resect it and anastomosis that loop, of course, so the bowel is okay. And they bring that loop down into the pelvis and they hook up the mesenteric supply up to the inferior upper gastrix. And in this particular case, they actually left a Doppler lead, that this like metallic wire that runs along the course of where you might imagine the epigastrix would supply this bowel. This Doppler lead is left in after surgery for a little while, so they can monitor the health of the segment. And so when they called me, what I thought is that this bowel looked really sick to me. We talked about the case. I realized that this was a neovagina ileal segment. And I basically said, this looks really sick and possibly ischemic. It's got all this bowel wall edema, mucosal edema. And then when we talked a little bit, we also found out that the Doppler signal had basically gone from the epigastrix, or at least the venous supply had. And then we went to surgery and resected this, and it was completely dead. And so unfortunately, this woman lost like 60 segments of small bowel in an attempt to create a neovagina, and I'm not really sure what the next steps will be. But apparently it is a pretty complicated surgery that can cause a lot of problems like this.
Ross,
Let me
I
just
have so
try
many
to-
questions, but one of my questions is
Yeah.
that whole 60 centimeters of bowel supposed to be the neovagina, or like there's one portion of it that's the neovagina and then the other small bowel that was like dragged along the process got ischemic?
Right, good question, because I don't really know. I've been trying to clarify this with the surgeons, and I need to follow up them directly. The surgical note describes a 20 segment of bowel, a 20 centimeter segment of bowel they brought down. But the path note after surgery, when they took this out, said 60 centimeters. And so obviously you don't need 60 centimeters of bowel to create a neovagina. I don't know if that's because that's where that arcade supply happened to go and they didn't feel like they could, resect less in order to keep the blood supply there or not. But for whatever reason, it's a pretty long segment. And that makes sense on what we're seeing on the CT, I think, right? Like this loop is way longer than 20 segments, if you ask me. It like comes way up here and loops down and around, and you can see the anastomosis over to the epigastric. So I don't know enough about this to know how often they take, X centimeters or not, but for whatever reason, in this case, they took a pretty long segment.
Cool. I'm imagining that they put 20 centimeters down below, but then the other 40 centimeters that was also attached to that same mesentery became ischemic too.
Yeah, that could be. So this is just for a quick show and tell. This is the penile inversion methodology, which is apparently retains a lot more of the sensation and can even retain some of the erectile tissue from the penis to create a clitoris that'll, function a little more physiologically. And I don't know why they didn't do this. They may just not do this at one of our hospitals, but this is sort of the other modern technique for this. So, and that's it.
Very cool, very complicated. Anyone else have any cases? I have one more acute one I can show if I don't crash. Let's see. Okay. So type into the chat or speak up. Let me know what you guys think about this one. This is one of the key images. We're looking at the uterus. And there is a uterine abnormality. Okay, so Kadar is saying septate, which I agree with because the outer contour here, and I can show you on the sagittal, but there's no divot between the two horns. But it's also, I don't know, I actually don't even know what this is truly called, but because below you can see actually that there's two cervices that are completely separate and there was actually two vaginas. So yeah, it's kind of in the spectrum of didelphys, but somehow up here they're fused. So it's fused up but not on the bottom. So it's kind of a combination. This is also courtesy of Omar. Thank you, Omar. Of a didelphys below with two cervices, two vaginas, and then it gets fused up here. And then this part was actually like a septate uterus. So yeah, you can actually even get combinations of this on the spectrum. And I think like it's because, the two sides are fusing. And so in this particular time, they just didn't fuse below, but they fused above, but they still have a muscular appearing septum above. And Rupa says none of these read the book. Yes. And some, nice ovaries here. So, okay, that's it for me. And if does anyone else have cases? Otherwise, we will just see you next time. Okay, see you guys later.